Thank you very much. So I introduced myself before, but what I didn't say is that I'm an endocrinologist and a trialist. By saying trialist, I mean that I have conducted over the years many large, randomized, double-blind, placebo-controlled trials with cardiovascular disease outcomes. These trials usually have anywhere between 3,000 and 10,000 patients. They last from 2 years to 5 years. And the trials that I've been working on are trials of the statin class of drugs. I am an adjunct professor of medicine at NYU School of Medicine. I also am an academic visitor at the University of Oxford in England. And I have no disclosures. So how many of you have treated patients with type 2 diabetes? Great, there's a lot of people in the room. But type 2 diabetes, as you know, is associated with high blood sugar levels. But what is really difficult in these patients is that they have an increased risk of cardiovascular disease. And that is what causes patients with diabetes. That is the most common cause of death. And you can see in this graph that cardiovascular death and also all-cause mortality are 2 times higher in patients with diabetes than patients without diabetes. So we must do something about this, and there are many interventions have been tried to reduce cardiovascular disease in these patients. And the ones in yellow are the ones that have evidence, proven evidence of benefit. That would be smoking cessation, cholesterol reduction with statins, blood pressure control, and use of aspirin in patients who have had a heart attack or stroke. In green is what I'm going to talk about today. There are some new drugs that lower blood sugar that also have a cardiovascular benefit. And I'm going to talk about 2 of these drugs. One is an SGLT2 inhibitor, and the other is a GLP-1 agonist. So what happened in this field is that somewhere around 2008, there were some reports that thiazolidinedione, rosiglitazone, was not safe for the heart and caused heart attacks and deaths. This report was actually proven to be not correct later on, but the FDA got concerned and they issued a guidance in 2008 to say that all new drugs for diabetes must have outcomes trials, must have large trials to look at cardiovascular outcomes, not for efficacy, but for safety. The FDA wanted to make sure that these drugs were safe for the heart. So the 2 drugs that I'm going to talk about in the 2 trials will be the EMPA-REG trial using the SGLT2 inhibitor empagliflozin and the LEADER trial using liraglutide, which is GLP-1 agonist. So what is SGLT2? Well, SGLT2 is a transporter that reabsorbs glucose from the proximal tubule of the kidney. If you inhibit SGLT2, then the glucose is not reabsorbed. You get glycosuria, more glucose is excreted in the urine. And this can cause some improvement in blood sugar and also some weight loss. So empagliflozin is an SGLT2 inhibitor. It reduces hemoglobin A1C by about 0.5%. It causes a small amount of weight loss, about 2 to 3 kilograms. It lowers blood pressure by 2 to 3 milligrams and does not increase heart rate. And some of the side effects are a small increase in LDL, 2 to 4%, and certainly there are urinary tract infections because of the glycosuria, female genital fungal infections in 5 to 10% of patients. The EMPA-REG outcome trial was one of the trials mandated by the FDA, and the people who designed the trial decided to test their drug in 7,020 patients. These patients were randomized and were double-blinded to treatment, and there were 3 groups: placebo in about 2,300 patients, the 10 milligram dose of empagliflozin in about 2,300 patients, and the 25 milligram dose of the drug. And the primary outcome was cardiovascular death, non-fatal MI, or non-fatal stroke. And what was done is that the 2 groups of empagliflozin were pooled, and that was pre-specified. So during this trial, there were some differences at 1 year versus the placebo in patients who were randomized to empagliflozin. Those patients had a small drop in hemoglobin A1C, 2 kilograms loss of weight, small decreases in systolic and diastolic blood pressure. There was no change in heart rate, and LDL went up by 5 milligrams per deciliter, which is really very small. So what was interesting are the results. This shows the increase in deaths, or in cardiovascular events, excuse me, not deaths, of the primary outcome in the placebo group. There were 282 events over 4 years, which is 12.1% of the placebo-treated patients. And here is the curve for the patients treated with empagliflozin. Build this again. There were 490 events, because there were double the number of patients, but only 10.5% of the patients, fewer than the placebo group, had one of these, composite endpoints of the composite endpoint. So there was definitely a benefit. The hazard ratio was 0.86, which means a 14% relative risk reduction. And this was really very surprising to us, because for years, we had thought that drugs that treat diabetes could reduce cardiovascular disease, but we never really could prove it. And this was one of the first trials, if not the first, that actually showed that. And if you look at the risk reductions in all-cause mortality, you can see that there was a 38% relative risk reduction in death from cardiovascular causes, and that's seen in the middle bar. There was also a decrease in all-cause mortality, which I can believe is true because the primary reason for that is the cardiovascular death. There was not an increase in death that was non-cardiovascular. And also in terms of hospitalization for heart failure, there was a surprising 35% relative risk reduction. There were 95 events in the placebo group, 126 in the empagliflozin group. The percentages, absolute percentages, were 4.1 versus 2.7%, and the hazard ratio 0.65, with a significant p-value of 0.002, showing that this is an extremely significant result. And this is something that we were quite surprised to see, but pretty happy about. So the safety data for this trial showed that there was, as expected, increased genital infection in men 5% versus 1.5%, and in women 10% versus about 3%. And there's a small incidence of urosepsis in the patients treated with the SGLT2 inhibitor. So now I'm going to turn to the GLP-1 agonist, Liraglutide. So Liraglutide is a GLP-1 agonist, and it binds to the GLP-1 receptor and causes insulin release from the beta cell in type 2 diabetes. So GLP-1 receptor agonists, as I just said, stimulate insulin release from the pancreas after eating before your blood sugars go up. They inhibit glucagon release. They slow glucose absorption into the blood. They slow gastric emptying. They reduce A1C by a little bit, by 0.5 to 1%, and they cause weight loss. And actually, they can cause a significant amount of weight loss. But of course, there are adverse effects, and these are usually gastrointestinal, such as nausea, vomiting, and diarrhea. And in animals, thyroid C-cell tumors were seen, but we have not seen this in any people. So the trial that was done was in about 9,000 adults with type 2 diabetes, and it was called LEADER. The previous trial that I showed was in patients with diabetes who definitely had heart disease. In this trial, the patients were at high risk of heart disease, but I'm going to continue. But they didn't have heart disease. So they were randomized to placebo or the 1.8 milligram dose of Liraglutide. As before, there were some differences between the Liraglutide group and the placebo group, with lower A1C, weight, blood pressure, and 3 beats per minute increase in heart rate. You can see that there was a 13% relative risk reduction for the composite primary outcome, which was CV death, non-fatal MI, or non-fatal stroke, as in the other trial that I showed, and this was significant for superiority. This is an important result. And there was a 27% relative risk reduction in death from cardiovascular causes, with a p-value of 0.007. So the adverse effects of liraglutide in this trial were that there were some more cases of pancreatic cancer, which has really worried us, and we're still investigating this. There were fewer cases of prostate cancer. We did not see medullary thyroid cancer. There were more gallstones in the patients treated with liraglutide, and of course in yellow you can see there were many GI symptoms. So in summary, what I've tried to say today in this short talk is that most adults with type 2 diabetes should be taking a statin, and if they have hypertension, medication to control blood pressure. Randomized controlled trials show that the SGLT2 inhibitor empagliflozin and the GLP-1 agonist liraglutide reduce atherosclerotic cardiovascular disease, including cardiovascular death, in patients with type 2 diabetes who either have cardiovascular disease or have a high risk of it. Empagliflozin also reduces the incidence of congestive heart failure and the progression of kidney disease, although I did not have time to show you that data. And it is not known whether the cardiovascular benefits observed with these two drugs are actually class effects. There have been many other trials, as the FDA mandated, with each of the other drugs, and the results are mixed. So practically, I think that these data are very exciting, and they give healthcare providers information that will help them make a more informed decision about which medications to use after metformin in their patients with type 2 diabetes. Thank you.